So what we'll do with this case is slightly more didactic, primarily because the audience, our audience today, is likely going to be much less familiar with some of the background surrounding insomnia and lifestyle change or cognitive behavioral kinds of treatments to begin with. So let's start really with two overview facts. First, insomnia is very, very common in patients with obstructive sleep apnea. In fact, and these data are now over 20 years old, but even among the stereotypical obstructive sleep apnea referral patient of the 1990s, in other words, someone with loud snoring, classically obese in the United States, they would be referred to an academic sleep medicine center several decades ago. These were patients who really very clearly were at high risk for obstructive sleep apnea. Even among those patients, there's still a prevalence of chronic insomnia of somewhere around 40 to 50%. And the literature has really been very, very clear. There are a number of potential physiologic mechanisms, which I'm happy to speculate about. Those data and the mechanisms aren't exactly clear, but certainly sympathetic activation is a major shared physiologic mechanism. The bottom line is that we used to think of sleep disorders patients in a very orthogonal way. These were obese patients with loud snoring who had obstructive sleep apnea, or these were kind of worried well, highly anxious patients with chronic insomnia. And over the past several decades, looking at data from the World Health Organization and the diseases globally that cost the most money, these always involve both a biological and a behavioral component. Think about obesity or smoking or cardiovascular disease and so on and so forth. So what we once thought was very clear either or, we now know is really much more complex and overlapping. When we talk about chronic insomnia, we simply mean trouble falling asleep, trouble staying asleep, or both. The frequency of insomnia is 3 nights per week for 3 months or more in terms of the diagnostic criteria. And generally, we use 30 minutes as a threshold for what is taking too long to fall asleep, or how long am I awake in the middle of the night. So if my sleep latency exceeds 30 minutes, or if my total wake after sleep onset exceeds 30 minutes, those are pretty good clinical rules of thumb for taking too long to fall asleep or being awake too long in the middle of the night. Of course, insomnia needs to be associated with a daytime consequence. These consequences run the gamut from cognitive dysfunction to fatigue or sleepiness or irritability or depressed mood. Obviously, there's a very broad range of outcomes of insomnia. And as you mentioned earlier, it's really incumbent on the physician to connect the dots, because patients sometimes don't even realize that their sleep is a problem. The population prevalence of insomnia is approximately 10% globally, although there's some variability. And in clinical practice, the population prevalence of chronic insomnia increases dramatically, approaching 50%. So chronic pain and chronic sleep trouble are two of the most common reasons why patients go to see GPs to begin with. Insomnia is associated with worsened mental health and physical health outcomes across a very broad range of disease categories. Insomnia diminishes quality of life, and insomnia increases economic costs. The disease categories in which insomnia is highly prevalent and in which insomnia worsens outcomes are very important, because we know that we can improve insomnia in many, in fact, all of these that I have listed here. We know that we can improve insomnia in these chronic conditions to improve sleep, improve quality of life, and in many cases, improve outcomes in the so-called primary disease state to begin with. So when pulmonary physicians, when respiratory physicians see patients with obstructive sleep apnea, they should also be asking, how long does it take you to fall asleep? How long are you awake in the middle of the night? And so forth. The most common treatments, as you mentioned earlier, remain pharmacotherapy, sometimes liberally prescribed. And we'll talk about the data in just a sec. There's nothing inherently wrong with thinking about pharmacotherapy for insomnia. However, we know that behavioral therapies produce longer lasting benefits, and certainly all of the consensus recommendations from the American Academy of Sleep Medicine to the National Institutes of Health and the American College of Physicians and the British Pharmacological Society and on, they all recommend what are called cognitive behavioral treatments, or CBT, CBTI, for the long-term management of chronic insomnia disorder.
Emerson, before you go to CBTI, how bad is this problem in your practice? How many referrals from primary care are already on a drug?
Many. And this is problematic for two reasons, because oftentimes when a primary care physician, we can't ask primary care physicians to be specialists. Right. And so primary care physicians can detect, and they often do, that sleep is a problem. Sure. But sleep, of course, to people on this call and to our audience today is really an umbrella term. There are insomnia disorders and sleep breathing disorders and neurologic conditions and so many things in between. Sure. So primary care docs can recognize sleep, and often what they will do, because it's one of the few tools that they have in their armamentarium, is they'll prescribe a sleep medication. Well, if that patient had obstructive sleep apnea, and as we talked about earlier, half of them do, right, then now what we're doing is we are suppressing the arousal threshold in patients who are struggling to breathe at night. So comprehensive assessment and thoughtful diagnosis are just essential, right? Assessment, diagnosis, prescription. We need to follow all three steps.
Sure, absolutely.
So there are a broad range of medications and over-the-counter medications, and increasingly CBD and so forth. Each of these have different risk-benefit profiles, but I want to make sure to give a nod that this is the status quo.
Sure.
No pill can teach your body how to sleep, but an evidence-based behavioral treatment can. Part of the problem when we're talking about chronic insomnia, not necessarily all of the problem, but a large part of the problem, is that through repetition, our patients have learned how to be very poor sleepers. Practice makes permanent. And obviously, there's a strong behavioral component to our sleep routines. There are virtually no adverse side effects to behavioral treatments for insomnia, although during the so-called sleep restriction phase, which I'll explain in a moment, patients will feel sleepier, so we need to make sure that they stay safe while driving and so on and so forth. Right. There are hundreds of clinical trials with moderate to large effect sizes demonstrating that CBT works. There's no question that CBT works in the majority of patients, including in many comorbid populations, as I mentioned earlier. This is a brief treatment, so this isn't a lie down on the couch and let's talk about childhood traumas. This really is a sleep-focused training intervention. And like many behavioral treatments, this has become increasingly manualized over time. And by manualized, what I mean is we want to make it paint by numbers so that it's easier for physicians or social workers or non-psychology professionals, non-behavioral professionals to implement these evidence-based treatments. Increasingly, there are online interventions and mobile phone interventions that are designed not only to make patients' lives better, but also to make physician practices and healthcare providers' lives easier as well. So let's talk about a case and use that as a starting point to expand our discussion. This is a 67-year-old male with primarily sleep onset insomnia, a BMI of 28, so he's normal weight, and he was diagnosed with mild, almost moderate obstructive sleep apnea. Past medical history significant for GERD and chronic knee pain, and no past mental health history. He takes an antihypertensive medication, and he also takes an over-the-counter sleep aid. As far as seeing patients in the sleep disorder center go, the patient is relatively unremarkable. He has chronic sleep onset insomnia and mild obstructive sleep apnea. This is a very common, it's a very common presentation. There's some chronic pain history here. The GERD is of course very common in untreated OSA. Now, I want to highlight here where Dr. Collop's cases, where Nancy's cases really, I think, emphasize the importance of fine-tooth, laser-focused read on the physiology and biological signals, and even for that matter, diagnostic test results. Insomnia is a more subjective presentation. It's a subjective clinical diagnosis. There is no diagnostic test. And in this case, let's take a look at what the patient's really telling us. During the day, the patient notes that he's having cognitive difficulties. He can't focus as well when he goes hunting, which he does for leisure. He's almost falling asleep in his deer stand. He talks about his eyes feeling tired during the day. He works at a hospital, and he is a part-time shift worker. And when he is at work during his shifts with no immediate stimulus to keep him engaged, he tells me that he just wants to go ahead and doze off. One of the things that's most important to the patient is he knows that he is irritable with his family, and he's aware of it, but can't quite stop himself because he's so sleepy and much more reactive than he'd like to be.
These are such common symptoms of insomnia. We see it every day, but we never put down that detail. When the patient talks, we just feel he's just tired, but there's so many other small points that I relate to.
These are and I'd encourage our audience, these are the kinds of questions that, when it comes to behavior change, really matter. In fact, in just a sec, we'll talk about how I open all of my clinical interviews. And now I train physicians of all backgrounds in providing comprehensive sleep medicine care, and all of them report that learning how to conduct the initial interview is the highest yield activity that they gain from rotating through the sleep disorder center. In terms of comorbid insomnia and sleep apnea, if you can't sleep, it's even more difficult to get used to CPAP than it was before. Earlier, I mentioned that it's very important how you begin your diagnostic interview. And so with all of my patients, and I see patients with obstructive sleep apnea, chronic insomnia, circadian rhythm disorders, those are probably the three most common disorders that I treat in my practice. And all of my diagnostic interviews begin the same way. And that is, if I had a magic wand, it could change anything about your sleep, what would you want that to be? And patients are generally a little bit stunned. And after they tell me they'd like more sleep or to sleep through the night, I ask them, how would your life be different? And for this particular patient, the way that his life would be different is he would be less snappy with his wife and family. And the reason it's so important to understand that is that I now know why the patient is here. And this is the carrot that I can then use to help motivate the patient to stick with some of the changes that may get worse before they get better, okay?
Fantastic. I think it's a wonderful approach.
In terms of putting together a treatment plan, one of the things that's important to understand about behavioral approaches is that they can really be highly personalized. So when we're talking about 4 to 6 sessions, some patients are 2, other patients are 9. We're really going to tailor our approach to exactly what's going on with this particular patient. Now, the patient, by the time they came to see me, had already failed at CPAP therapy, which of course makes my job a little bit harder, but it's going to be a very common experience for our audience, and that's why I thought this would be a useful case. This is a patient who knows that they have trouble sleeping. They were told they had sleep apnea, and they didn't want to have anything to do with CPAP. And behavioral treatments that focus on motivation are the currently most effective interventions to increase CPAP adherence. So what we do with this patient is we develop a combined approach. In this case, what the patient did was elect to begin with onset insomnia. And what I do, which I'll show you on the next slide, is begin to think about how can we get a win on the onset insomnia side and then add CPAP when the patient's ready. So questions to consider in a case like this are what is the pre-sleep routine and what is the bedroom environment? The bedroom environment needs to be cool, dark, quiet, and uncluttered. And what is the patient doing that may be activating his pre-sleep arousal, where it's causing him 60 minutes or more sleep latency each night? What's he thinking about? Are there real or perceived stressors where we might be able to make progress? What's his somatic activation? And what are the patient preferences? Is this a patient where we want to focus on a regimented approach and using behavioral language? Or is this a patient that is open to or interested in approaches like mindfulness or meditation or yoga? And I'm going to talk about treatment. Treatment's not going to change necessarily, but the way I talk about treatment will change based on what that patient is bringing to the table. What are his knowledge, attitudes, and beliefs about CPAP? Unfortunately, most patients have not been well educated about CPAP or well supported about CPAP early in the course of care. And then what's his confidence to change? Does he think that he can do this? In this particular case, you'll see that sleep latency, it was taking the patient almost an hour. All of these data are based on sleep diary. This was a 6-session encounter, and patient's verbal report, sleep quality's gotten much better. CPAP use has increased. Unfortunately, the machine was old, and so we don't have any of the lovely objective information that Dr. Kolb showed, but the patient verbal report was that we were wearing CPAP now most nights 2 to 3 hours a night, which is an improvement from where we were. Patient verbal report is of increased daytime energy level, and just overall sleep satisfaction has increased. The patient is falling asleep faster. It was originally taking almost an hour to fall asleep, and now it's taking less than that 30-minute threshold. The patient is getting over an hour more of sleep each night. You can see that the patient used to be awake more than an hour during the night, and they're now awake less than 20 minutes. And the sleep efficiency has increased also within to the normal range. So this is a very common case for comorbid insomnia and obstructive sleep apnea, and I'm happy to answer questions.
I think that's fantastic, because I think comorbid insomnia in sleep apnea is just labeled as anxiety very often, and no one looks, very few people look into the aspects you have talked about, Emerson.